slide, you see two players impacting on one another. You are attracted by the players. But we, as orthopedic surgeons, are attracted to the knees of one of the players. You see that his tibia is in external rotation, and the femur is an internal, and the knee is flexed. So he has a fourth flexed injury, external rotation of tibia and femur. There is a derotation injury. And when you look at this, you kind of wonder, did this patient have an ACL injury? Did he have any other injury with it, the PCL? Did he have a medial collateral ligament injury? And this is what we will be discussing. Now, if you look at the knee from above, you should have an idea about the position, the insertions of each of the ligaments, and what structures exist in between the joint. Recently, we spoke about the menisci. We spoke about how they are shock absorbers, and of how they obtain their nutrition, which one is more mobile than the other. Today, we will be discussing about the ligaments about them and the attachments of the menisci. You have to know the anatomy very well to deal with these conditions, especially if you want to do arthroscopy and arthroscopic management. Looking at the knee from behind, you have to know the medial femoral condyle, where it is, what is attached to it. On the lateral aspect of the medial femoral condyle, you have the ligament of Rissberg, which is the most posterior. Then you have the posterior longitudinal ligament and the posterior cruciate ligament, sorry, and the posterior cruciate ligament and its two bundles, the anterolateral bundle and the posteromedial bundle. You should know about the lateral femoral condyle and the relation of the tibia and fibula to each and every structure. Anteriorly, you should know about the anterolateral ligament or bundle of the anterior cruciate ligament and the posteromedial bundle. Also, if you look at the sides, you have the lateral collateral ligaments and the medial collateral ligaments. This is the side looking at the lateral projection. You can see the patella tendon in front. You can see the medial patellofemoral ligament. You can see the medial patello-meniscal ligaments. You can also see the semimembranosus and the superficial medial collateral ligaments. You have to look at these. You have to have in your mind clearly where are each of the ligaments. Look at the MPFL, which is the medial patellofemoral ligament, of how it's attached to the patella and to the posterior to the adductor tubercle, just beneath it. So you have to think of these structures. Likewise, over here, you have the fibula collateral ligament, the posterior oblique ligament, and you have the posterior muscle or peroneus muscle, and the peroneofibular ligament. You have all these structures over here. You have to know each and every of these structures. When you're doing an arthroscopy, you should distinguish between the ligamentum mucosum and the anterior cruciate ligament. You should know where the fat pad is present. All these structures are essential to know about them. Then, when you look at the lateral aspect of the knee, you see anteriorly you have the anterior cruciate ligament, posteriorly you have the posterior cruciate ligament, and these stabilize the femur in line with the tibia. So you have to keep these in mind. One holds the femur, the tibia anteriorly, the other one posteriorly, but one is more than important than the other, namely the ACL is more important than the PCL as far as the knee is concerned. In addition, you have to know the relation biomechanically, and you have to know that the knee joint is a compound hinge model equivalent and describes the three-dimensional kinematics of the knee. And you have to know about the trans-epicondylar axis and an axis parallel to the longitudinal axis of the tibia. You have to know these. You have to read about them. You are usually asked about them in exams. So if you have an internal rotation of the tibia on the femur, you'll increase the strain on the anterior cruciate ligament, and this can, in extremes of motion, lead to a tear, and it would lead to a trauma areas within the femur and tibia, and these have become apparent, very apparent on MRI, which has helped us quite a bit in the diagnosis of these lesions. You have to know about the patella and its extension proximally and distally. You have to know about the biomechanics of the patella and its tracking through the trochlear groove, and in conditions with lateral patella dislocation, where is the situation, what is the problem, and what are the conditions that lead to it. These are what are required in boards. We like to ask a lot about patella subluxation and dislocations. We'd like to ask about the types of trochlea that we have. We have to ask about the alignment, the line of pull of the quadriceps in respect to the infrapatellar tendon. And if it's too lateral, you'll get a faulty tracking. And as a result, this is one of the predisposing factors to lateral subluxation or dislocation of the patella. You have to also know about the examination. The examination, what should you do? You should examine the patella. You have to examine for any apprehension the patient has, and you should examine for the laxity about the patella. In addition, don't forget about patella apprehension, meaning that the patient is lying supine and you're stressing the patella laterally. You see that the patient would jump up and would want to catch your hands because he is afraid to have a dislocation or he has pain. In addition, one should palpate the patella during flexion and extension to observe the tracking of the patella. If you have maltracking, the patella will go laterally as the patient is flexing. In addition, following an injury, routinely you should examine for the cruciates, do an anterior drawer sign and a posterior drawer sign, and you have the sagging phenomena. If the patient lies supine and is flexing his knees, you have to know the situation where the tibia lies in relation to the femur. You see that it glides posteriorly, indicating that the posterior cruciate ligament is torn and there's no support, and as a result, it glides posteriorly. The anterior cruciate ligament is most commonly injured during sports-related activity, with a minority of ACL injuries occurring in high-energy trauma or activities of daily living, but is most commonly injured in sports. You can see it, a basketball player is jumping to grab the ball, and he lands on his legs. He has a hopping jump in energy force, and this can the foot can land improperly, resulting in an ACL tear, and suddenly following this, the patient will have swelling of the knee, and this is due to a hemarthrosis, due to a tear of the ACL. If you look at this, you have to look at the ACL of its position, where it attaches to the lateral, to the medial margin of the lateral femoral condyle, and inserts in the anterior intercondylar eminence. And it has two bundles. You have the posteromedial bundle, and you have the anterolateral bundle. So one is tight in flexion, and the other is tight in extension, meaning the posterior medial bundle is tight in extension, while the anterior longitudinal bundle is tight in flexion of the knee. Approximately 70% of patients hear or feel a pop at the time of the injury. You have to keep this in mind. Almost all patients notice swelling, and this is, if it's torn, it's due to a hemarthrosis of the knee, and this appears within 24 to 48 hours following the injury. Injuries may be classified as contact or non-contact injuries. Non-contact injuries usually occur with cutting or pivoting injuries, twisting injuries. The reasons for the higher rate of injuries among females is not clearly understood. But I'll tell you simply that you look at the intercondylar space in females, it's less than that of males. This could be one point. Another point, usually females are not well or prepared for that particular sports. Nowadays, they're becoming more trained and preparing them much better. Potential contributing factors include biomechanics, alignment muscle strength, hormonal factors, and training. The overwhelming majority of ACL injuries are complete disruptions in the skeletally mature patient. The femoral insertion or mid-substance is usually the site of disruption. In the skeletally immature patient, the tibial attachment may be a valve with or without a piece of bone. If you look at this is a child who had such an injury, and you see that the intercondylar eminence together with the fragment of bone and the ligament is detached. We are seeing them quite often, and we see them quite often in bicycle injuries. So, and these we are reducing them arthroscopically, putting screws or holding them with certain sutures. And this is a well-known condition to occur in children. How should we evaluate them? An appropriate and detailed patient history can raise suspicion for an ACL injury. The patient who sustains a knee injury during sports activity that is followed by sudden knee swelling should be carefully evaluated for a possible ACL injury. ACL or anterior cruciate ligament injuries are also extremely common during skiing. Let me tell you this. During the changement of the ski poles and the boots in the past were lower down. We used to receive patients following injuries, fractures of the tibia. With the elevation of the boot, the strain and force is coming totally on the knee. And for this reason, we're having more and more anterior cruciate or even posterior cruciate ligaments. Conversely, ACL injuries are less common among snowboarders. Why? Because the boots are different. Don't forget this. In the setting of chronic ACL injury, the patient may have recurrent episodes of knee injury. Mechanical symptoms from a secondary meniscal tear or frank instability. What should we know on physical examination? In the board exam, we can get you a patient who has this injury. How should you manage it? How should you examine the patient? In the setting of acute ACL injury, physical examination can be difficult or limited, secondary to pain. Don't forget that this patient has pain. Effusion is related to hemarthrosis, secondary to bleeding from the vascular torn ligament. The knee should be palpated carefully with attention focused on the joint lines and the femoral origin of the medial collateral ligament in particular. Patient apprehension or movement of the patella should be noted, because let me tell you something. You can confuse a lateral patella dislocation, which has reduced spontaneously with an ACL injury. So acute patella dislocations often present with a history that is very similar to ACL injuries. Keep this in mind. If we get a patient, tell us the differential diagnosis. And why do they confuse? Why are you confused with them? Why? Because both present with pain, both present with hemarthrosis. And the two injuries can be confused in the acute setting. The quadriceps and patella tendons also should be examined in the acute setting, as tendon ruptures may be confused with ACL injury. Just look at the patella. What is the patella? Is it high riding? Does the patient have a patella ulcer? Does he have a gap in the suprapatellar region secondary to rectus femoris rupture? You have to examine the patient and look for these things. The Lachman test is the most useful in diagnosing ACL injuries in the acute setting. Why? Because it gives us the least amount of pain when we're examining the patient. And how do we do it? Look at the slide. Look at the position of the hands. Look at the right hand where he has it holding the femoral component downward and in a stable position. Look at his left hand. He has it behind the calf and is pushing up anterior. Why is he doing this? Because he wants to rule out whether the ligament is torn and it is allowing the tibia to move forward on the femur. So, in the Lachman test, the distal femur is held securely in one hand, while the examiner translates the tibia anteriorly with the other hand. A sense of increased movement and lack of a solid endpoint, lack of the tibia holding well with respect to the femur, are indicative of ACL injury. The collateral ligaments must also be assessed for stability with varus and valgus stress and rotation. The posterior cruciate ligament must also be examined. Ideally, this is done with the knee at 90 degrees of flexion. However, this maneuver is often difficult in the acute setting because the patient is in pain. Neurovascular injuries do occur, and they must be ruled out by assessing motor and sensory function, as well as pedal pulses. You should always examine for the dorsalis pedis artery and the posterior medial area by the posterior tibial artery. Rule out vascular injuries. It won't take time to examine for them. With posterolateral corner injuries and a varus stress, what would you think? You have varus, and the whole tibia is being pulled forward. What structure do we have? We have the peroneal injuries can also be found. Just one moment. عباتي محاضرة لبرا ما بفضى غير للساعة 6. إذا بدك تلفن لي بعد الساعة 6. Okay, sorry about that. What about the pivot shift test? I'll tell you, my dear children, my residents, my listeners, in the examining board, we examine for all physical examinations. Most commonly, it is the knee. Why? Because we have so many tests that we can do on the knee. The pivot shift test is pathognomonic for ACL injury, and it helps us in missed conditions, in chronic conditions. This test begins with the knee in full extension, and the knee is then flexed while applying a valgus moment. As the iliotibial band passes posterior to the axis of knee rotation, which is at approximately 15 degrees of knee flexion, meaning the tibia, which is subluxated anteriorly on the femur, and as it's being flexed, it reduces with a visible shift at the lateral joint line. This reduction tells us that the ACL is torn. During full extension, there's nothing to hold it, so it will sublux. When you flex, there are other structures, and it will reduce into position. Of course, this should always be compared with the contralateral side, where a physiologic pivot shift or pivot glide may occasionally be present. The patient who does not have a clearly positive examination for an acute ACL injury may have a partial ACL injury despite a positive MRI finding. Partial ACL injuries require strict physical examination and visualization criteria. Partial injuries may or may not withstand future trauma. So you have to be ultra careful. And this, if it's torn completely, it will allow the knee to give way. What about imaging? How does imaging help us? Radiographs are useful in the acute setting to rule out a fracture. In the skeletally immature patient, radiographs should be evaluated for open physis, particularly because this can impact on surgical options. The MRI is not required for the diagnosis of ACL injury, but it is useful for assessing the meniscal pathology, subchondral fractures. And what we see, if you ask for an MRI, you see that the radiologist reports most often of bone bruises, either in the femoral condyle or in the proximal tibia. And it will help us to rule out other ligamentous injuries. The edema pattern of MRI, particularly in the acute setting, relates to transchondral fractures in the posterolateral tibial plateau and in the anterolateral femoral condyle. And it is indicative of a translational event that is likely secondary to an ACL injury. Following the ACL injury, you have instability. This causes a direct impaction on the femoral condyle and the posterolateral plateau. Indications of this are given to us by MRI. You see that there is edema in the region. When we see edema in this region, we tell you, hey, be careful, you have an ACL injury. In sagittal and coronal MRI scans, ACL injuries appear as disruptions in the normal black ACL fiber. You see that there is a disruption. Let's look at this. This is a lateral view of the knee. And it is a T2 weighted image in MRI. And it demonstrates a bone bruise of the anterolateral femoral condyle and the posterior lateral plateau due to an anterior translation of the tibia in respect to the femur following an ACL injury. Meaning that the posterolateral component of the tibia impacts on the lateral femoral condyle. It gives you this edema, and you say, my dear, you have an ACL injury. So be careful of this. What about the treatment? Non-surgical, individualized treatment is appropriate for patients with partial injuries to the ACL, including those with low-energy skiing injuries who may have a good outcome with non-surgical treatment. Non-surgical treatment involves rehabilitation to strengthen hamstrings and quadriceps, as well as proprioceptive training. Activity modification is also an important part of non-surgical management, as patients who avoid cutting and pivoting sports are at lower risk for knee instability. ACL sports braces are available as well. However, they have not been shown to prevent abnormal anterior tibial translation. Functional braces and simple knee sleeves improve proprioception, which may give patients a sense of improved knee function and stability. What are the surgical indications? In the acute setting, the decision to reconstruct the ACL is generally related to the patient's activity level. Patients who are older or less physically active may elect to modify their activities and proceed with non-surgical treatment. If non-surgical treatment fails or knee instability persists, surgery can still be performed. Athletes with ACL injuries rarely return to cutting and pivoting sports such as basketball, football, soccer, squash, handball, without first undergoing surgery. They need surgery to return to these sports. For individuals who wish to return to such sports, surgery is generally recommended to avoid instability and secondary meniscal and or articular cartilage damage. The decision about whether ACL injury is needed for an individual to return to sports activity is not always obvious. Many recreational skiers who do not participate in cutting and pivoting sports can often function well without surgery. Individuals who work in occupations that may involve physical combat, such as police officers, or risk, such as fighters, should have ACL reconstruction before returning to work. Most patients can function well and perform activities of daily living without instability after a complete anterior cruciate ligament injury. However, some have difficulty performing even the activities of daily living because the anterior cruciate ligament deficiency related instability that they could have would require them to have surgery. What are the contraindications? The contraindications include lack of quadriceps function, significant comorbidities, or inability to tolerate the surgery. After an acute injury, patients should not have surgery until they have regained full range of motion. Be careful. When you get the patient, you see that he has an ACL injury, don't immediately say you want to do surgery. You should put them through a set of physiotherapy to regain the full range of motion. They should have good quadriceps function, and you should be in control of effusion, and they should have a normal gait. Patients who undergo ACL reconstruction before swelling has been eliminated and don't have a full range of motion has been established, they are at higher risk of having arthrofibrosis, scarring tissue, limitation of motion, and they would have all the complications that one could have following an ACL repair done at the improper time. Advanced osteoarthritis is a relative contraindication. Patients with osteoarthritis may have significant pain after the surgery despite a stable knee. Therefore, they may not experience a satisfactory outcome. And for this reason, you have to warn your patient. If he insists on having an ACL repair, then you should tell him, being that you have osteoarthritis, there is a risk that you might have more pain, even though you have a stable knee. What are the surgical procedures? The most important surgical factor is a well-performed technique, not the specific type of technique, not whether you've used a bone, tendon, bone graft, not if you use any of these pes and serenus tendons as ligament substitutes. You have to do the proper technique. You should position the insertion and the origin in the proper location. You should not position them too anteriorly, because you'll find that it will impinge on the notch and you will get an early failure. So keep this in mind. You need to know the technique properly and how to apply it properly. Graft choices include autologous bone patella tendon bone, autologous hamstring tendons, autologous quadriceps tendon, and allograft tissue. The clinical outcomes are the same if you use this, that, or that. You have to position. You have to make the tunnel move in the proper positions. There is no definite evidence regarding superiority of using a bone patella tendon bone autograft versus a hamstring tendon autograft. A bone patella tendon bone autograft may have a lower re-rupture rate than a hamstring tendon autograft, but the bone patella tendon bone procedure is associated with more post-operative pain from the donor site, a higher risk of post-operative anterior knee pain, particularly when the patient kneels. Mind you, you took that fragment of bone from the patella. If he wants to pray or if he kneels, they will have pain. When you take the hamstring tendons, you don't have this pain. If you apply a proper technique, they are nearly the same as the result is concerned. The risk of patella or tibia fracture, although very rare with a bone patella tendon bone autograft procedure, is virtually eliminated when autograft hamstring tendons are used. So you have to keep this in mind. There has been a trend toward increasing allograft use in the United States. But most studies published to date on allograft reconstructions involved in older patient population. Don't forget that allograft tissue carries a risk of disease transmission. Don't forget this. We ask this in exams. What about the results? Reconstruction of the ACL generally results in excellent outcomes, with most patients returning to their previous level of activity. They are happy, believe me. The autograft choice and the use of one or two incision techniques do not appear to affect the outcome. The re-rupture rates vary from 2 to 5% according to the literature. Instrumented laxity with KT1000 arthrometer has demonstrated 75 to 97% of patients have less than 3 millimeters of side-to-side difference in laxity. So it gives you a stable position. It maintains the relationship between the femur and tibia. It prevents impaction between these two bones. So it's giving us very good results, providing it is properly done. But don't forget that complications do occur. Deep infection following ACL reconstruction is uncommon. It's less than 1%. But when it does occur, deep infection may require repeat arthroscopies for irrigation and debridement, as well as possible hardware removal and removal of graft to eradicate the infection. Deep infection involving the knee are generally treated with 6 weeks of intravenous antibiotic therapy. Knee stiffness is generally uncommon and can usually be resolved with physical therapy. It is more common after multi-ligament reconstructive surgery. In some cases, repeat surgery or manipulation under anesthesia may be required. Thromboembolic disease is uncommon, but patients with a family history for this condition or with hypercoagulability may be considered for an anticoagulation. Painful hardware at the proximal tibia near the tibial tunnel can lead to repeat surgery for hardware removal, should this be sufficiently disabling for the patient. And this, I realize, happened with me many times. If you're using a bone tendon bone graft, a tendon bone tendon graft, if you put your tibial component through the tunnel with the fragment of bone, and you find it's too long, you'd have a tendency to leave a bit out. This can irritate the patient. This can bother the patient. What you should do, you should bury it well. You should not be prominent in its location. And if it does bother the patient, you might have to use, if you have used non-absorbable interference screws, you have to remove them. Loss of full extension can occur. Don't forget this. Secondary to the scarring from the graft, or if, please pay attention, if you find that there is a torn in the mid-substance of the ACL or the anterior cruciate ligament, you have to make it a point to excise it till its insertion. You have to excise it because it will result into a cyclops lesion, which is a scar formed in the intercondylar notch blocking excision. The treatment, you have to go in and excise it. This can require repeat surgery to remove the tissue that blocks full extension. So don't forget this. A cyclops lesion resulting from incomplete removal of the tendon insertion that was torn could lead to this. And as a result, they will lack extension. What about revision surgery? When evaluating a failed ACL reconstruction, the surgeon must attempt to determine the etiology of the failure. Graft failure is classified as biologic, traumatic, or related to technical failure. Revision surgery is more technically demanding due to the existence of prior tunnels and hardware. Can you imagine yourself reinserting a tendon graft in areas where you have made previous tunnels? Where are you going to localize them? Allograft tissue is often preferred for revision surgery because graft tissue is not limited and harvesting from the contralateral leg is not necessary. The outcome following ACL revision surgery appears to be inferior compared with primary reconstruction, although the reason for this is not well documented. Pearls and pitfalls. Tunnel placement is the most critical aspect of ACL reconstruction. The most common error in anterior cruciate ligament reconstruction is to place either the tibial or femoral tunnel too anteriorly, as I have repeatedly mentioned. This leads to graft impingement on the trocheoplasty or the shaving that you have caused, and this would lead to failure due to impingement. There's no free motion. The more you place these anteriorly, the more the impingement. When using a single incision technique, the tibial tunnel should begin at the anterior part of the tibial insertion, arrive of the MCL to allow the graft to be placed obliquely and arrive at the 1030 or 130 position on the intercondylar notch of the femur. This is very important. If you use in the past, when you do arthroscopy, when you do these repairs, there were two techniques. One was to prepare the tunnel of the tibia, and then when it comes out at the intercondylar eminence, through that hole, prepare the femoral component. This led to many problems, and for this reason, we use two tunnel views, two separate tunnel views. And we aim at not putting the femoral tunnel too anteriorly. We just pass it just anterior to the posterior cortex. Be careful about this. If the tibial tunnel is placed too anteriorly on the tibia, the graft will be vertically placed in the femur, which is not desirable. So if you use two separate tunnels, You can control each individually. It is important to understand that the direction of the tibial tunnel influences femoral tunnel placement with the use of a single incision technique. If the femoral tunnel is drilled through the tibial tunnel, don't use it. This problem can be avoided by drilling the femoral tunnel through a separate medial port. Be careful about this. What about the rehabilitation? A post-operative leg immobilizer is not required after the first day or two. After surgery, with modern fixation techniques, patients are allowed to bear weight that is stand as tolerated with crutches. They can then ambulate with the crutches until they can walk. Normally without them, which is generally 1 month after surgery. They use crutches, but they use it for 1 month, not more. But we allow them early ambulation. Patients are then allowed to start light running between 3 and 4 months if they have progressed sufficiently with strengthening. Return to sports is generally not allowed until 6 months after surgery. For most patients, it is allowed between 6 and 12 months, depending on their rate of progression with rehabilitation. Now we come to the posterior cruciate ligament. I would like to mention that I mentioned nothing incomplete concerning the ACL injuries. But this is what we require for the first 5 years of training. For 5 years of training, we expect you to know how to examine the knee properly. We expect you to have knowledge about the ACL, that it has 2 bundles. We expect you to know that the bundles are tightened at different times, one in flexion and one in full extension. And this is very natural. Posterolateral in extension. The anterolateral in flexion. We like you to know that these ligaments form a cross with the posterior cruciate ligament. You should know that they are tight in full extension. You should know that if you want to examine for the medial collateral ligament, you have to flex the knee to around 30 degrees to relax these cruciate ligaments. You should know that as you're doing an anterior cruciate ligament substitute, you have to make sure that you've removed the ACL insertion completely so as not to have a cyclops, and as a result, they will have limitation of flexion. At the end of a procedure, you want to make sure that you have done and treated the patient well. You have to do the pivot shift test. And you can do the drawer test, but these are all tests that you should do. The anterior cruciate ligament is far more important than the posterior cruciate ligament, which we will be discussing now. Khalid, am I clear so far? Khalid, Saleh, am I clear?
It is clear, doctor.
Clear, okay.
Clear, very clear.
Okay, Faizan, I'm going to carry on with the posterior cruciate ligament.
Okay, bro, go on.
The PCL is the primary restraint to posterior tibial translation in the intact knee. It is the exact opposite of the anterior cruciate ligament, which was the primary restraint to anterior tibial translation in the intact knee. What about the incidence? 5 to 20% of all ligamentous injuries to the knee involve the PCL. And many of these injuries are believed to go undiagnosed in the actually injured knee. Injuries to the PCL may be isolated or combined with other capsuloligamentous injuries in the knee. Although the diagnosis of a combined PCL injury may be obvious in a knee subjected to high energy trauma, an isolated PCL injury may be less obvious because instability is often subtle or even asymptomatic. Let me tell you something. Many PCL injuries go as misdiagnosis. If a PCL injury occurs, what takes over the function? It is the posterior horn of the medial meniscus. With time, this can be torn because it's taking all the load. Many times we miss PCL injuries, and the incidence is rare. It is much rarer than ACL injuries. It occurs in 5 to 20%. So one should keep this in mind. What about the pathoanatomy? If you're looking at the knee from behind, you can see the ligamentous attachments of the PCL. You see it clearly on the lateral view of how it originates from the proximal tibia posteriorly and goes and inserts on the lateral margin of the medial femoral condyle. You have to keep this in mind. So keep this, please. 2 bundles. Behind it lies the ligament of Vrisper, and these are attached somewhat to the lateral meniscus. And you have the ligament of Humphrey. Keep these in mind, please. You have to know the anatomy. Usually it's a direct blow to the proximal aspect of the tibia, and this is the most common cause of PCL injuries. So keep this in mind, please. In athletes, the mechanism of injury is usually a fall onto the flexed knee with the foot in plantar flexion. Why in plantar flexion? When it's in plantar flexion, all the load is taken more proximally on the proximal aspect of the tibia, and the forces applied from anterior to posterior, tearing the PCL. So it applies a posterior force on the tibia and subsequently causes rupture of the PCL. And in this slide, look at the diagram below. You look at the direction of the arrows. The force is coming from the front posteriorly, and this stretches the posterior cruciate ligament in the second portion of the slide. A high energy trauma, such as motor vehicle accidents. The PCL is often injured with other capsuloligamental structures. When 3 or more ligament structures are injured, when 3 or more are injured, the physician should view the injury as a dislocated knee. Be careful. If you have multiple ligamentous injuries, look at it as if, and the knee is reduced as if the patient developed a dislocation and reduced spontaneously. The natural history of these injuries is not entirely clear, but there is evidence that certain PCL injuries, especially combined with, will progress to instability, pain, and osteoarthritis of the knee. So don't look at PCL injuries as being totally innocent. There have been reported cases where the patient ended up having osteoarthritis as a result of the continuous instability that was present. How should we evaluate them? Again, I stress, physical examination is very important. We have a lot of cardiovascular effects, a good portion on how well you perform your physical examination. We observe you. We see the position of your hands. We see the position of your eyes. We see the position of the tibia in relation to the femur. We call it the quadriceps sag test. And we ask the patient to extend the knee. We see that this sagging phenomena, secondary to contraction of the quadriceps, will bring the tibia forward due to the insertion of the patella and its infrapatellar tendon onto the tibial tuberosity. It brings it forward. What about the history? The history of the injury helps differentiate between high and low energy trauma, dislocation, neurologic injury, and additional injuries based on mechanism may further assist in the evaluation of these patients. The physical examination relies heavily on the posterior drawer test. However, the Lachman test for ACL injury testing for varus and valgus and testing for external and internal rotation are critical in differentiating between isolated and combined injuries, meaning that both the ACL PCL may be injured, meaning that thus the posterior capsular components may be injured. You have to make sure that these don't occur in combination. A knee with an isolated PCL injury will exhibit a positive posterior drawer test at 90 degrees, which translates as greater than 10 to 12 millimeters in neutral rotation. Pay attention very carefully what I'm telling you now. In neutral rotation, when you do a posterior drawer test, the tibia will translate posteriorly greater than 10 to 12 millimeters. But this will be reduced to 6 to 8 millimeters of posterior translation when you put the knee in internal rotation. So it decreases with internal. A combined PCL and capsuloligamentus injury, when the PCL is injured in conjunction with other structures such as the ACL, posterolateral corner, or medial side, a positive posterior drawer test at 90 degrees will be greater than 15 millimeters in neutral rotation and greater than 10 millimeters in internal rotation. So the more you have ligamentous injuries associated with the PCL, the more you'll have translation, whether in neutral or internal rotation. Please keep this in mind. What about imaging? Plain radiographs are important initially to rule out fractures and avulsions to ensure that the knee is not dislocated. The key is to recognize that when the knee with an intact ACL and PCL is centered in the sagittal plane, the tibia is anterior to the femoral condyles. Pay attention to this. Where does the tibial tuberosity lie in relation to the femur? You see that it is anterior to the femoral condyles. This is what you can tell on X-ray, plain X-ray. And this would tell you, if this is anterior, then you said, hey, the ACL and PCL does not look torn. MRI complements the history and physical examination, and it helps to determine the site of injury and the continuity of the PCL. MRI findings may also influence treatment strategies. Keep this in mind. Let's look at this slide. You see that this is an MRI of an acute PCL injury. If you look on the left side, you see that the initial MRI, the lateral view, showing the PCL injury. It's torn completely. And follow-up MRI lateral view shows healing of the PCL. You see that it's one structure. Okay, pay attention to this. What about the classification? PCL injuries do occur in isolation or in combination with other injuries. The types of PCL injuries are listed. I wonder if I put the table, let me see. Yes, very good. The treatment is non-surgical. Non-surgical treatment is reserved for isolated PCL injuries or combined PCL injuries in totally non-compliant patients. The PCL can heal in this scenario if the patient is relative immobilization. Yani, and I've had PCL injuries torn, and after a few weeks to 1 month to 2 months, I did a repeated MRI and I'll find that it would heal to the adjacent anterior cruciate ligament. And we had sufficient stability in comorbid patients, in elderly patients, or inactive patients. So one should keep this in mind. And you have to give them quadriceps strengthening exercise. Now, if you have a PCL injury, you can classify it into partial, complete, isolated, and combined PCL with capsular ligamentous injuries. The partial, you have a translation less than 10 millimeters on the posterior drawer sign or test with the knee in neutral rotation. Okay, some sort of endpoint is present. So it's only less than 10 millimeters. If you have complete isolated, the PCL alone is injured, physical examination is normal, posterior drawer test is positive with the knee in neutral rotation and is diminished with the knee in internal rotation. Why? Because the posterior capsule takes over the control. Combined PCL and capsulo-ligamentous injuries, the PCL is injured in conjunction with other structures such as the ACL, posterolateral corner, and medial side. So I think that this slide is important because it tells you the different types of PCL injuries. And this gives you the classification into partial, complete, isolated, and combined PCL and capsulo-ligamentous injuries. And this gives you an algorithm of what you should do with an acute PCL. If it's isolated and if it's grade 1 to 2, you treat them conservatively. If it's grade 3 and you have a young athletic patient, we don't operate often. Usually, we put them in an immobilizer, full extension, we avoid posterior tibial subluxation, and we give them physical therapy and quadriceps exercise. If we have an avulsion, of course, we have to operate. If we have a complete combined PCL, LCL, MCL, and ACL knee dislocation, then operative surgery is performed in less than 2 weeks. Why? Because we don't like scar tissue to develop after 2 weeks. And we expect the hematoma, the hemarthrosis to subside by that time. And what about PCL reconstruction? Surgical treatment is indicated for isolated chronic PCL injuries when there are continued instability symptoms, particularly when ascending and descending stairs and inclines, and for combined PCL and capsulo-ligamentous injuries. What about the surgical procedure? The PCL can be repaired in avulsions and augmented or reconstructed. Reconstruction can be done via a femoral tunnel technique with a tibial inlay or tibial femoral tunnel technique. In addition, single bundle anterolateral or double bundle anterolateral and posteromedial femoral tunnel techniques have been popularized. Allograft tissue is usually utilized for single bundle and double bundle reconstruction. Achilles tendon is often used, but patella tendon bone, hamstring tendons, anterior tibialis tendons are viable options. This is how we repair. This illustration, it is simple, but you have to know about the posterior approach. You have to have good experience. If you want to do it arthroscopically, you have to be well trained. And if there is a bony fragment, you should reduce it, insert a screw with a rondelle or one of these rondelles, we call it in French, where we put our screw in, and then we make a tunnel through the lateral surface of the medial femoral condyle. This gives us good results. This shows you another technique, again, making separate tunnels. This is likewise, both showing you the position of how you put your interference screws with the tendon and you hold it well and the reduction occurs. How do we do it? We insert a guide from the anterior aspect of the tibia. Okay. Then once we're through, we pass our tendon, and then we make other tunnels separately. we start from the lateral aspect of the medial femoral condyle outward. We prepare the way for the bone graft. We insert our tendon through it, and we put our interference screws. This shows it to you once it's done. No clinical outcome studies in the literature clearly support one technique over the other, in addition to the 1 versus 2 femoral tunnels and the tibial tunnel versus inlay technique controversy. There is controversy about the best tissue for reconstruction. Graft choices include autologous middle third patella tendon bone, autologous quadriceps tendon bone, allograft bone, patella tendon bone, allograft Achilles tendon bone, semitendinosus tendon, and gracilis tendon. The tissue preference is based on training and availability and not on any outcome studies. What are the complications? Patellofemoral pain and or arthritis. Chronic PCL deficiency can occur as a result of increased dynamic stabilization by the quadriceps. Neurovascular injury can be devastating complication. And for this reason, I tell you, you have to know the anatomy very well. Failure to reference the tibia in relation to the femur can lead to misdiagnosis. Knee instability occurs less frequently with isolated PCL injuries than it does with ACL injuries. Rehabilitation should focus on quadriceps strengthening and reducing patella pain. Now we come to the medial collateral ligament and posteromedial corner. Are there any questions? Any questions? No questions? I will carry on with the medial collateral ligament and the posteromedial corner. The tibial medial collateral ligament is the most commonly injured ligament of the knee. Pay attention. I asked in one of the board exams, which ligament is the most common ligament to be injured in the knee? Many put the ACL. This is not the most common injured ligament. The ACL is the most common injury that occurs in sports. But as a whole, the medial collateral ligament is more common than the ACL. The true incidence may be underestimated due to a lack of reporting for lesser grades of injury. This I compare to Lisfranc's fracture of the foot. Lisfranc fracture, when the patient comes to the clinic with swelling, and you take an x-ray, everything is reduced, but you're not doing your x-ray when the patient is weight-bearing. And many people don't bring the patient back for another x-ray and ask for an x-ray while weight-bearing. And for this reason, we miss quite a number of Lisfranc's fractures. Likewise, the medial collateral ligament is not taken seriously. We don't report it so much, but it is the most frequent. Concomitant ligamentous injuries that occur with it and 95% are the ACL. And it occurs in 20% of grade 1 injuries, 52% of grade 2, and 78% of grade 3 injuries. Concurrent meniscal injuries have been reported in up to 5% of isolated medial ligamentous injuries. So pay attention to this. What about the anatomy? You have to know the anatomy of the medial collateral ligament. You have to know that there's a superficial and there is a deep component. You have to know these. You have to know which ligament you resect when you're doing a total knee. You cannot remove both superficial and deep ligaments. You have to look into this. You have to know that they are old injuries that we don't know about them. And you have a fragment of bone. Look at it here. I'm going to point it. This is the site. And this extra bone is due to an avulsion of the femoral component of the medial collateral ligament. And this is known as the Pellegrini Stiada lesion. We love to ask this question. Around the knee, you have the static stabilizers and you have the dynamic stabilizers. You have to pay attention to this. The medial capsular ligamentous complex is composed of 3-layered sleeve of static and dynamic stabilizers extending from the midline anteriorly to the midline posteriorly. The posterior oblique ligament, the POL, the deep MCL, middle capsular ligament, do exist. You have to know these. Dynamic stabilizers, the semimembranosus complex, composed of 5 insertional attachments. You have the pes and serenus muscle group, which are the sartorius, the gracilis, and the semitendinosus muscles, the vastus medialis, and the medial retinaculum provide abduction stability under dynamic conditions. So you have to know these. What are the dynamic stabilizers of the knee? Don't forget this. Don't forget the pes and serenus group. And I follow them by a name. S, G, S, M. You have to pay attention. The S for the sartorius, G for the gracilis, and the semitendinosus, S, and muscles. You have to pay attention to this. The vastus medialis, medially, has something to do. The medial retinaculum, all these function together with the medial collateral ligaments. They are stabilizers to abduction of the knee, to any valgus fall. The biomechanics of the medial capsulo-ligamentous restraints. The main function of this complex is to resist valgus abduction, valgus, and external rotation loads. The superficial medial collateral ligament is the primary restraint to valgus loads. Posterior oblique, deep medial collateral ligament, and cruciates are secondary restraints to valgus stress. Evaluation. History. Lesser degrees of medial collateral strains result from a non-contact valgus external rotation force. Look at the slide. Look at the player, what has happened to his knee. He has a valgus force occurring in the region of the knee. You can imagine the strain on these dynamic and static structures of the knee. Complete disruption usually results from a direct blow to the lateral aspect of the knee. Occasionally, a pop is noted by the patient. The ability to ambulate and or continue to participate in athletic activities depends on the degree of disruption, whether it's grade 1, 2, or 3, the player's position, and the presence of concurrent injuries. A bit about the physical examination. The knee should be inspected for ecchymosis, localized tenderness, and the presence of infusion. Abduction stress testing should be performed with the knee at 0 degrees and 30 degrees of flexion. If you recall, I told you we don't examine for the medial collateral ligament in full extension. Why? Because the cruciate ligaments take over that function together with it. When you flex to 30 degrees, you're relaxing the cruciate ligaments, and all the strain will be on the medial collateral ligament. The superficial MCL is isolated with a valgus stress at 30 degrees of flexion. Pathologic laxity is indicated by the amount of increased medial joint space separation compared to the opposite normal knee. Grade 1, 1 to 4 millimeters opens. Grade 2, 5 to 9 millimeters, and grade 3, which is a complete tear, is more than 10 millimeters. Valgus laxity with the knee at or near full extension implies concurrent injury to the posterior medial capsule, medial collateral ligament, and the cruciate ligament. Why? Because the cruciates are tight in full extension. So if it goes into valgus, it means that they're cut together with the medial collateral ligament and the posterior medial capsule. So you have to keep this in mind. So, summary of medial collateral evaluation. If it's stable in 0 degrees of extension, then either grade 1 or 2, non-surgical treatment. If increased at 0 degrees, then grade 3 with injury, posteromedial, consider ACL, PCL, and combined injury. So you have to pay attention. Evaluation of associated and other injuries. The Lachman and the anterior drawer tests should be performed to rule out an ACL injury. The pivot shift test is often falsely negative in the presence of a grade 3 MCL sprain. A PCL injury is assessed by palpation of the tibial condylar step-off and posterior drawer sign, both performed at 90 degrees of flexion, the quadriceps active test, and observation of the posterior tibial sac test. We spoke about this recently. Patella apprehension and tenderness over the patella and medial retinaculum indicates a positive patellar dislocation. I put this again. Don't forget about the posterior sag sign. Look at the tibia of how it's sagging behind the femur. Always test and do a posterior drawer test to rule out a PCL also. So keep these in mind. The diagnosis An isolated medial meniscal injury is suggested by medial joint line tenderness, the absence of pain to valgus stress, and an increased pain on flexion rotation testing McMurray test. This is indifferential to an MCL injury. These are the various tests I have spoken to you so much. The only one I didn't tell you about is the Apley compression test. The Apley compression test distinguishes between meniscal injuries and ligamentous injuries. If you apply pressure on the foot and you internally rotate and externally rotate, the tibia is impinging through the menisci onto the femur. And as you rotate, this will result in pain. If you don't have pain and you apply traction on the tibia while in flexion and rotate, patient has pain, it tells you it's a ligamentous injury. You have to know how to do a McMurray test, do an anterior drawers test. You have to know how to do a pivot shift test and the Lachman test. Please keep these in mind. What about imaging? Plain radiographs are typically normal, but should be inspected for fractures, lateral capsular avulsion. A Segan's fracture. What is a Segan's fracture? It's an avulsion of the capsule. And this is a sign that an ACL injury has occurred. Pellegrini sciatica. This is an avulsion, proximal, in the proximal femur, in the femur, around the condyles. And this is a sign of an MCL injury. Stress radiographs may be indicated in skeletally immature individuals to rule out a physeal injury. MRI has become the imaging modality of choice to evaluate the injured MCL. The advantage of MRI are that it identifies the location and the extent of the injury, and it is useful in ruling out associated meniscal, chondral, or cruciate injuries. The disadvantage of MRI are that it is expensive and reader dependent and may overestimate the degree of injury. The classification sprains of the MCL are classified based on the extent of ligamentous disruption and resulting degree of patholaxity. And this we repeated. This is the classification that we routinely use. Treatment, non-surgical indications, all isolated grade 1 and 2 injuries, grade 3 injuries that are stable in extension without associated cruciate ligaments should be treated conservatively. Contraindication, gross laxity to valgus stress at 0 degrees and sometimes 30 degrees of flexion, which implies concurrent ligamentous and or capsular damage to the ACL or PCL combined injury. I've repeatedly told in full extension, the PCL and the ACL are tight. When you get a rupture of the MCL, but these are present, you won't get any opening. But if you find that valgus instability and its opening, then it tells you that the ACL and the PCL is torn together with the medial collateral ligament. A grade 3 injury with the ligament displaced into the joint is also an indication for surgery. The procedures and protocols, crutches, ice compression, elevation, and anti-inflammatory pain medications are initiated. No brace is usually required for grade 1 injuries. Crutches can be used as necessary, a knee immobilizer comfort or hinged brace for walking is recommended for grade 2 and grade 3 injuries. Quadriceps setting and straight leg raising are initiated immediately for all injuries. Cycling and progressive resistant exercises are started when tolerated. Thigh adduction exercises should be performed above the level of the joint. A low profile open hinged brace is used for grade 2 and 3 injuries as activity improves and for a return to sports. The complications, proximal injuries, are associated with difficulty obtaining full motion. Distal injuries are associated with residual laxity. Asymptomatic residual laxity is typically seen following the conservative treatment of grade 2 and 3 medial collateral ligaments. Residual rotatory knee instability during cutting and pivoting activities is seen when there is an associated unrecognized ACL injury. A Pellegrini Stiada lesion, calcification of the femoral origin of the MCL is common and may become tender from direct pressure over the bony mass. What are the pearls and pitfalls? Grade 1 injuries result in the production of minimal swelling or effusion. The presence of a large effusion implies a grade 2 injury and or concurrent ligamentous or cartilaginous injury. Grade 3 injuries are associated with disruption of the joint capsule and allows any accumulated effusion to leak into the soft tissues, resulting in only a small palpable effusion. I would like to warn you at this stage, if you're doing anything arthroscopic, and if you have a capsular tear together with the medial collateral ligament or any form of ligament, and you want to do it arthroscopically, please be aware of the amount of fluid pumped into the knee, because this will go into the soft tissues, and the known complication is Barton syndrome. Be very careful of this. MRI is indicated for a significant effusion, an inconclusive cruciate examination or suspicion of a concurrent meniscal or cartilaginous injury. The timing of returning to sports is directly related. Just 1 second, I want to see what that. سوري، هيدا معلمكم خالد عم بيقول لي انه هو مسافر وما قادر يحضر بقى. سمع اول بار. على كل حال we will carry on. So the timing of return to sports is directly related to the degree of injury. Grade 1 injuries is 5 to 7 days. Grade 2 injuries, 2 to 4 weeks. and grade 3 injuries, 4 to 8 weeks. The timing of ACL reconstruction with a concurrent MCL injury should be delayed proportional to the degree of MCL injury to allow for ligament dishealing. A rough estimate is as follows. Grade 1 injuries, 3 to 4 weeks. Grade 2 injuries, 4 to 6 weeks. And grade 3 injuries, 6 to 8 weeks. Rehabilitation activities are progressed based on the athlete's ability to reach specific milestones, jogging agility, drills, sport-specific drills, and return to sport. The athlete should be pain-free during these activities before progressing to the next level. Surgical indications. Isolated grade 3 injuries with persistent instability despite attempted supervised rehabilitation and brace. Grade 3 injuries with valgus laxity in full extension, greater than 10 millimeters of medial joint space opening. Ligament entrapment within the medial compartment. Chronic valgus instability with associated cruciate deficiency. Grade 3 injuries with PCL or ACL-PCL combined injuries. The contraindications, all grade 1 and grade 2 MCL injuries. Grade 2 and grade 3 injuries, grade 3 injuries, stable to valgus stress in full extension. So the retain to play are full range of motion, no instability, muscle strength of 85% of the contralateral sides, proprioception ability is satisfactory, no tenderness over the medial collateral ligament, no effusion, quadriceps strength, torque body weight, and use of a lateral knee brace if necessary. Surgical procedures, acute repair. Diagnostic arthroscopy is recommended to rule out associated damage. Ligament avulsions should be reattached with suture anchors with the knee at 30 degrees of flexion. Interstitial disruption warrants attachment of the MCL to its femoral and tibial origins with anterior advancement. Once the MCL is repaired, the POL is advanced anterosuperiorly to the adductor tubercle and distally to the tibial metaphysis. So you have, this is the MCL, you have the POL lies posterior to it, you have the medial posterior capsule. You have to pay attention to these as you're repairing. Posterior part of the MCL, the posterior oblique ligament, the ACL, the medial posterior capsule, and possible the PCL. These can be repaired. This is a magnetic resonance imaging showing a complete avulsion of the superficial and deep medial collateral ligament with an unattached medial meniscus. Pay attention to it, the round circle. This shows it at surgery. Surgical procedures, chronic reconstruction. If sufficient tissue remains, proximal advancement of the femoral origin of the MCL with attached bone block and advancement of the POL is recommended. If insufficient local tissue remains, a semitendinosus, autograft, may be used to reconstruct the superficial MCL with isometric fixation using a screw and washer to the medial epicondyle. Allograft, hamstring, tibialis anterior, Achilles tendon may also be used for chronic instability. So you have to pay attention to this, please. Complications. Loss of motion, flexion and extension is the most common complication following surgical treatment. Injury to the saphenous nerve may be temporarily, namely neuropraxia, and if it is stretched, it can be an exantemesis, or if it's permanently damaged, it's a neurotemesis. So pay attention to this. The pearls and pitfalls. MRI can be useful in planning a limited surgical exposure based on the location of injury, proximal or distal. For primary repair, knee motion should be checked after the placement of each suture. Limitation of motion of suture disruption indicates non-isometric suture placement. Now coming to the lateral collateral ligament and the posterolateral corner. Injuries to the lateral collateral ligament and posterolateral compartment are reported less commonly than injuries to the medial side of the knee, in part due to lack of recognition. Between 7 and 16% of all knee ligament injuries are to the lateral ligament. This shows you a patient who has a lateral collateral ligament damage, and it shows the external rotation recurvatum test showing severe posterolateral corner injury. In these injuries, you have to pay attention to the peroneal nerve because they can tear, they can rupture. The lateral compartment of the knee is supported by both dynamic and static stabilizers. The dynamic stabilizers consist of the biceps femoris, the iliotibial band, the popliteus muscle, and the lateral head of the gastrocnemius muscle. The static ligamentous arcuate complex consists of the fibula, lateral collateral ligament, the popliteus tendon, and the arcuate ligament. These show you the fibular collateral ligament, the popliteofibular ligament, shows you the lateral gastrocnemius, all take part in stabilization of the lateral portion of the knee. This shows you, it's picturistic, showing you the same structures I just spoke to you. So you have the dynamic. The lateral capsular complex of the lateral aspect of the knee is divided into thirds. The anterior third attaches to the lateral meniscus anterior to the lateral collateral ligament. The middle third attaches proximally to the femoral epicondyle and distally at the proximal tibia, and the posterior third located posterior to the lateral collateral ligament. The biomechanics of the lateral capsular ligaments. The lateral collateral ligament is the primary restraint to various stress at 5 to 25 degrees of knee flexion, providing 55% of restraint at 5 degrees and 69% restraint at 25 degrees. The popliteus restricts posterior tibial translation, external tibial rotation, and varus rotation. What about the evaluation? Injuries to the lateral ligament of the knee most frequently result from motor vehicle accidents and athletic injuries. Lateral ligament injuries result from either a direct blow or force to the weight-bearing knee, resulting in excessive varus stress, external tibial rotation, and or hyperextension. A posterolateral directed force to the medial tibia with the knee in extension is the most common mechanism of injury. Combined injury to the cruciate is more common than isolated injury to the lateral and posterolateral structures. Instability in the active patient is most commonly noted with the knee near full extension. Patients may experience difficulty ascending and descending stairs, as well as with cutting or pivoting activities. Patients may also report lateral joint line pain. Physical examination, adduction stress is performed at both 0 degrees and 30 degrees of knee flexion. Isolated laxity at 30 degrees is consistent with injury to the lateral collateral ligament. Laxity at both 0 and 30 degrees is seen with additional injury to the ACL and PCL or arcuate complex. The standing apprehension test, as force is directed medially, the patient experiences instability and the examiner can feel the femur rotate on the tibia. So you have to pay attention. Over here, the doctor is supporting the leg in the lateral position. But if you direct the force medially, you see that they would have an apprehension test and would tend to fall if they have tears of the lateral collateral ligament. The posterolateral drawer test is specific for rotatory injury to the posterolateral corner test. This test should be performed at both 30 degrees and 90 degrees of flexion. A positive test at 30 degrees is most consistent with a posterolateral injury. A more pronounced test at 90 degrees of flexion implies associated PCL injury. This is a posterolateral drawer test. The dial test. The dial test is performed at 30 degrees of flexion and is considered positive when the involved foot and ankle exhibit more than 10 degrees of external rotation compared with the normal side. The external recurvatum test is performed with the examiner lifting the great toes of both feet with the knees in full extension. A positive test is indicated by both lateral knee hyperextension and external tibial rotation. Let us look. If you look at the slide on the left side, this is total normal. There is symmetry between both feet. On the right-hand side, you see it's more externally rotated. And this is done with the patient in the prone position. A dial test is performed in the prone position. A test performed with the knees bent at 90 degrees, showing symmetric external rotation in the slide on the left. A test performed with the knees bent at 30 degrees, showing increased external rotation on the right side. It can be at 30 or 90, consistent with posterolateral corner injury. This is the recurvatum of the posterolateral corner, where you can hold the toes up and you see the recurvatum. This can be the posterolateral corner or in combination with the PCL injury. In the reversed pivot shift test, the knee is taken from flexion to extension, reversed to regular form of pivot shift test from extension to flexion. So the knee is taken from flexion to extension with the foot held in external rotation while a valgus force is applied. With a positive test, the tibia reduces with a shift or jump from its posterior subluxated position at 20 to 30 degrees of flexion. With chronic injuries, an evaluation of gait is important to detect the presence of varus or hyperextension thrust gait. You see that there is a lateral thrust gait. There's nothing to support the knee posterolaterally, especially if the lateral collateral ligament is gone with the posterior capsule. So you have to think of this. This is the reverse pivot shift taken from flexion to extension with pressure on the lateral aspect of the knee, promoting a valgus stress as you're extending the knee. When the tibia reduces, it gives you a pop sign. This is the lateral thrust gait. This occurs with posterolateral injuries, and you would walk with the varus hyperextension thrust, and you should look for varus alignment of the tibia. Neurovascular injuries, common peroneal nerve injuries, in lateral collateral ligament injuries and posterolateral corner, and even the popliteal vascular structure injuries in the knee dislocation. And these are associated with the patterns of knee ligament injuries. Evaluation of the neurovascular structures is imperative, as up to 29% of patients with acute posterolateral corner injuries have peroneal nerve deficit. So please pay attention to this. Imaging. Plain radiographs should be obtained for all patients with suspected injury to the posterolateral corner to rule out an associated osteochondral fracture, a fibula head avulsion. Many times you see that the fibula head is fractured, but you never think of the posterolateral corner. So this lets you think of it. Gerdy's tubercle. You have to pay attention to this. Avulsion or fracture of the tibial plateau. A Stevens fracture, lateral capsular avulsion, is often seen with an ACL injury. Chronic posterolateral instability may show lateral tibiofemoral or patellofemoral degenerative changes. MRI is the imaging modality of choice to evaluate the status of the lateral collateral ligament, the popliteus tendon, and the cruciate ligament. But you need a good specialist to read them and point them out to you. You, at the beginning, should take your MRIs and discussing it with the radiologist. You should not read the report and depend on reading the report to make your diagnosis. With time, as you discuss it with the radiologist, you will learn how to read it. And when you graduate, you should not need a radiologist to read your MRIs. At the universities, at both American universities in Lebanon, we won't respect a resident at graduation who cannot read the MRI properly. We ask a lot about the MRIs in the end. You have to learn not to depend on others. MRI will provide information about the severity, mild sprain versus complete tear, and location, avulsion versus mid-substance tear of injury. Classification. Instability can be defined as either straight or rotatory, depending on the degree of associated patholaxity. Isolated injury to the lateral collateral ligament resulting in coronal plane laxity, straight instability is rare. Rotatory instability resulting in multiplanar laxity is seen with combined injury to the LCL and either the ACL and mid-third capsular ligament, anterolateral instability or arcuate ligament, popliteus tendon, and fibula ligament, posterolateral instability. Combined instability patterns may occur either as acute or chronic injury. Chronic isolated injury to the lateral collateral ligament is rare, as most patients with chronic injury to the lateral collateral ligament eventually develop associated injury patterns involving the posterolateral corner structures. Posterolateral corner injuries are often classified as grade 1, 2, or 3 sprains, depending on if there is minimal, partial, or complete ligament disruption. A more accurate classification is based on the quantification of lateral joint opening as compared with the normal contralateral knee with varus stress. This is a classification of posterolateral corner injuries, and this is the grade. 1 plus is 0 to 5, 2 plus is 6 to 10 millimeters, and 3 plus is 10 without an endpoint, and there's no limitation. And I won't go through this. The treatment of non-surgical treatment of ligamentous injuries to the lateral side of the knee is limited to partial grade 1 and grade 2, as for other ligaments. Isolated injuries to the lateral collateral ligament without involvement of the arcuate complex. These patients have little functional instability, especially if they possess valgus knee alignment. Non-surgical treatment consists of limited immobilization with protected weight bearing for the first 2 weeks, progressive range of motion, quadriceps strengthening, and functional rehabilitation are then initiated as tolerated. Contraindications to non-surgical treatment include complete injuries or avulsions of the lateral collateral and combined rotatory instabilities involving the lateral collateral ligament and posterolateral compartment structures. The most common complication of non-surgical treatment of these injuries is progressive varus, hyperextension laxity due to unrecognized associated injuries to the posterolateral structures. Return to sports can be expected in 6 to 8 weeks. What about the surgical indication? Complete injuries or avulsions of the lateral collateral ligament, rotatory instabilities involving the lateral collateral ligament and arcuate ligament, popliteus tendon, and fibullar ligament. Combined instability patterns involving the lateral collateral, posterolateral corner, and ACL or PCL. Surgical procedures, acute injuries, surgical options for acute injuries include primary repair of torn or avulsed structures and reconstruction if the native tissue is of sufficient quality. Surgery is usually recommended within 2 weeks of injury to prevent the formation of scar tissue and distortion of tissue planes that could hinder a direct pressure repair. Surgical procedures, acute injuries, arthroscopy is recommended to assist in the diagnosis of all torn structures as well as many meniscal or chondral injuries. Suture anchors can be used to repair avulsed structures. Direct suture repair can be used for mid-substance injury. Surgical procedures, chronic LCL and posterolateral corner insufficiency. You can use allograft. It has been used to form either a single-stranded graft, a bone patella tendon bone, to reconstruct isolated LCL injuries, or a bifid graft, such as the Achilles tendon, to anatomically reconstruct multiple injured structures, including the LCL, the popliteus, and popliteofibular ligament. How do we do it? One, the surgical anatomy. You have to know well. You have to expose the area. You have to pay attention that the peroneal nerve lies posterior, just adjacent to where all the work in good scope is being done. And we make a tunnel through the fibular head. We pass our tendon through the tunnel. And we put the screw and the bolt proximally in the femur. And then pass our tendon around it. Look, this is how we make it. We make our incision. The peroneal nerve lies just posterior to the fibula. You have the Gerdy's tubercle. You have the fibular head. You do it in between. This is the incision. And you extend to the lateral epicondyle. Look where the position of the peroneal nerve is. This is very important. You make your hole. You make a tunnel horizontally through the fibula. You pass your tendon around the bolt, and then you tie your sutures. This is how it looks at the final end. Complication, persistent varus or hyperextension laxity is often seen with advancement of attenuated lateral and posterolateral structures in chronic injuries. Injury to the peroneal nerve can occur during surgical exposure of the fibular neck or during drilling or graft passage through a transfibular tunnel. Complications, loss of knee motion usually occurs with the reconstruction of multiple ligaments, especially the ACL. Hardware irritation most commonly occurs at the lateral femoral condyle. The results of surgery performed acutely have a more favorable outcome than surgery performed for chronic laxity. All ligamentous deficiencies should be addressed to prevent persistent rotatory instability. Previously described methods of anterior femoral advancement, Houston procedure, or resection of the attenuated arcuate complex are no longer recommended for chronic instability. Use of the biceps femoris as a reconstructive graft is not very popular. It does not prevent external rotation, and it eliminates the biceps as a dynamic lateral stabilizer of the knee. Ligamentous reconstruction of the ACL should involve placement of the graft tissue directly to the fibular head rather than to the lateral tibia to optimize the graft isometry. Identification of the peroneal nerve is best done just over the fibular head and then traced proximally. Long leg casting is recommended for the first 4 post-operative weeks to prevent external tibial rotation that may occur with the use of simple hinged knee brace. Full-length upright radiographs of both the lower extremities should be obtained for all patients with chronic instability to assess for the presence of varus mechanical access. In these cases, a high tibial osteotomy is recommended before ligamentous reconstruction. This shows you a patient where he was in varus, the ligaments were repaired, but had the valgus osteotomy done at the same time. Multi-ligament knee injuries are usually caused by high-energy trauma and are often considered knee dislocations. Less frequently, low-energy trauma or ultra-low velocity trauma in obese patients can also result in this injury pattern. A bicruciate injury or a multi-ligament knee injury involving 3 or more ligaments should be considered a spontaneously reduced knee dislocation. A knee dislocation should be considered a limb-threatening injury, and careful monitoring of the vascular status after the injury is imperative. This shows you look at the tibia of how it's moving forward with respect to the femur. It tells you the anterior cruciate is gone. And of course, the posterior cruciate. Multiple ligamentous injuries. The multi-ligament knee injuries are usually caused by high-energy trauma and are often considered knee dislocations. Less frequently, low-energy trauma or ultra-low velocity trauma in obese patients can also result in the injury. So you have to pay attention to the vascular status. Multi-ligament knee injuries most frequently involves partial or complete rupture of the cruciate ligaments. Rare cases of knee dislocation have been reported with one cruciate intact. Most commonly, either the medial or lateral side of the knee will also be injured. Like this is involvement, a coronal magnetic resonance image of a left knee injury with bicruciate rupture and a complete posterolateral corner injury, including the arcuate fracture, as pointed out by the arrow. You have to pay attention to this. And a grade 3 injury of the fibular collateral ligament, popliteus tendon, and popliteofibular ligament. All these are. When high energy trauma is involved, occasionally both medial and lateral side injuries can accompany the bicruciate injury. Popliteal artery injury is estimated to be 32%, or peroneal nerve injury, 20 to 40% also can occur. Extensor mechanism injuries, quadriceps or patella tendon or patella dislocation also is encountered in this injury pattern. Associated fractures can complicate management of multi-ligament injury knee, and definitive fixation of unstable fractures should be performed first in a staged fashion or concomitantly with a knee ligament injury. A bit about the evaluation. A high index of suspicion for a reduced knee dislocation should accompany any knee injury that involves 3 or more ligaments. Mechanisms of injury, position of the knee when it was injured, and the timing of the injury are all important historic factors. A history of previous knee injury and current function are also relevant, as are age, activity level, and previous surgery or other injuries. You have to examine the blood vessels. You have to look at the ankle brachial plexus index, brachial index. All these should be looked at. And you should pay attention whether it's less than 0.9 or more. If there is any concern about abnormal vascular examination, there should be a low threshold for ordering an angiogram. If pulses are still abnormal or absent following a reduction of the dislocation, immediate vascular surgery consultation with intraoperative exploration should be the next step in management. A vascular injury in the knee dislocation, estimated at approximately 32%, is a limb-threatening injury and needs to be corrected within 6 to 8 hours. If not corrected, amputation may be required. Neurologic examination also is critical. Peroneal nerve injury should be investigated. Swelling should be assessed. A patella examination should be conducted to assess the extensor mechanism, integrity, and stability. The range of motion should be determined. Stability testing is critical, including anterior and posterior drawer test, posterior sag test, Slackman test, varus and valgus testing at 0-30 degrees, and dial testing at 30 and 90. Assessment of gait and pivot and reverse pivot shift testing can be performed in more chronic multi-ligament injuries. Plain radiographs are an essential part of the initial evaluation of multi-ligamentous knee injuries. Associated fractures, including the fibula head or PCL tibial plateau, avulsions, may affect the timing of surgery and early open reduction, and internal fixation of these fractures may improve healing. In chronic multi-ligamentous injuries, knees, standing, long cassette alignment films should be obtained to evaluate lower limb alignment. Often radiographs can reveal posterior tibial subluxation, reviews, and widening. So MRIs have its place in these diagnoses and to judge how many ligaments are there. And you have to pay attention. If you have a posterior dislocation, you can have the dimple sign. So this is what I'm trying to say. And there is a classification for multiple ligamentous injuries. You should know about them. And treatment of multi-ligament injury knee that presents as knee dislocation. Emergent closed reduction and splinting or bracing should be performed immediately. Post-reduction radiographs should be taken to confirm the knee reduction. And you have to pay attention. In elderly, you don't need to do much, but put them in a splint until healing has occurred, put them on physiotherapy, etc. But if you have a young individual, then you have to treat them surgically, repair the ligaments. Non-surgical treatment is contraindicated in the presence of comorbidities or concomitant injury patterns described above, irreducible dislocations. You have to operate. Neurovascular injuries, you have to operate. Despite these contraindications, surgical stabilization may still be pursued in a staged fashion after healing of the associated fractures or vascular repair or bypass. So the complications can have persistent knee instability, can have knee stiffness or loss of motion. Treatment should include a relatively short period of immobilization in full extension, followed by protected range of motion in those patients that you have not operated. But in patients you have operated, the same post-op treatment should be, and if the patient has arthrofibrosis, he needs to have physiotherapy. And you should monitor the gait to avoid chronic dynamic instability pattern, such as a varus thrust is important. If fracture requires skeletal stabilization, this care should be carefully coordinated with the trauma team to ensure appropriate placement of incisions for future planned ligament stabilization. If vascular repair is necessary, a consultation with the vascular surgery team about planned incisions, timing of future ligament repair, and motion limitations should be initiated. Complications include persistent knee instability, arthrofibrosis, and gait abnormalities, such as a fixed varus deformity or dynamic varus thrust can occur. Surgical indications, I'm not going to go through these because this is a hell of a job, but you have to know what to do with what ligaments and how to apply them. Okay, so this is enough for the ligaments because I think I've gone so much about it. This I have taken from the Arab board question. Let me, from the review call. First of all, an effusion after knee injury is related to hemarthrosis and secondary to bleeding from vascular torn ligament. This you should keep in mind. MRI evidence of a bone bruise pattern in the area of the anterior lateral femoral condyle and posterior lateral tibial plateau is pathognomonic of ACL injury. The most important surgical factor is well-performed technique, not the specific type of technique. And the type of graft, as I mentioned before, is not important. Of how well you perform the technique is what is important. The most common error in an ACL reconstruction is to place either the tibial or femoral tunnel too anteriorly. Grade 1 and 2 MCL injuries that are not stable in 0 degrees of extension are treated non-operatively. Valgus laxity with the knee at or near full extension implies concurrent injury to the posteromedial capsule. and or cruciate ligaments. Increased external rotation of the tibia at 30 degrees, but not at 90 degrees, suggests posterolateral corner injury. Increased external rotation at both 30 and 90 suggests that both the PCL and posterolateral corner are gone. Neurovascular injuries are common peroneal nerve injuries. The lateral, collateral, and posterolateral corner and popliteal vascular structure injuries do occur in this location. They are associated with patterns of knee ligament injuries. A bicruciate injury or multi-ligament knee injury involving 3 or more ligaments should be considered a spontaneously reduced knee dislocation. Knee dislocation is a limb-threatening injury requiring a careful monitoring of the vascular status. Now I'm going to come to patellofemoral joint disorders, but I'm going to discuss it very quickly so as to complete the topic. First of all, you have to know that the patellofemoral joint is a complex structure in which the patella articulates with the femoral trochanter. You have to know that the patella is the largest sesamoid in the body. It serves as a fulcrum for extensor mechanism, and as a result, high loads are transmitted across the patellofemoral joint. So you have to pay attention to this. Disorders of the patellofemoral joint typically arise from joint overload or instability. Joint overload can be caused by overuse or excessive force, and often is exacerbated by mechanical or structural variations that contribute to kinematic alterations within the joint. So, patellar instability is partial or complete displacement of the patella from the trochlear groove. The stability of the patellofemoral joint is influenced by the interaction of multiple anatomic factors, generally are categorized as static soft tissue restraints, osteochondral constraints, dynamic restraints, lower extremity alignment. What about the anatomy? What we need to know is about the medial patellofemoral ligament. This is the primary static restraint of the lateral to lateral translation within the first 30 degrees of knee flexion. You have to pay attention. A cadaver dissection study described the femoral origin of the medial patellofemoral ligament as 9.5 millimeters, 9.5 millimeters, and 9.5 millimeters, and it's distal and anterior to the adductor tubercle. And this shows you it. This is the medial patellofemoral ligament, how it is located, and it inserts on the medial aspect of the patella. So you have to pay attention to this. I'm not going to go. This is Lumisat's line. I just want to go through this lecture very quickly because you have to know the depth of the trochlear. And the way we measure it, we draw a line parallel to the posterior condyles, and then we draw lines tangential to the medial and lateral condyles proximally, and this would give you the sulcus angle. Now, to know about the height of each side, we draw perpendicular lines passing from the supracondylar regions. Most commonly, this is parallel to the posterior condyles. We measure the height of each, and it would tell us the difference. If it is significantly displaced, this would be a trochlear aplasia. These are congenital, and this predisposes the patella to dislocation. And we use this, and we use CT scan for these measurements. So you have to pay attention to this. So this is a point you should realize. And you should realize something, that femoral anteversion and gynovalgum were greater in knees with patellar instability and in healthy controlled subjects. So you have to keep this in mind. And in addition, you should look at the tibial tuberosity, see whether it's too lateralized. If it's too lateralized, this is one of the predisposing factors. So aplasia, femoral anteversion and rotation, and lateralization of the tibial tuberosity, all are important factors. Also, the patella height and patella alta, where you have a long infrapatellar tendon, this predisposes the patella to dislocation. So you have to pay attention. Patella alta is one of the factors. So you have to evaluate these patients and in details to be able to tell what is the future of this patient. So in addition, we found that patients with Ehlers-Danlos syndrome, where they have general ligamentous laxity, they have been associated with an increased risk of patellar instability. Also, one should measure the Q angle. If the Q angle is high, this also predisposes the patient to recurrent dislocation of the patella. Rotational malalignment is important. Femoral anteversion is important. And the way you diagnose this is by looking at patient standing. You see that patient knee are squinting. This patient has femoral anteversion and in association with recurrent dislocation of the patella. You can see it in the right-hand side in the middle figure. There is squinting of the patella. So you have to also look at the quadriceps strength. This predisposes the patient also. Lack of flexibility of the hamstring musculature and tightness of the iliotibial band. And this is detected by the Ober test. You have to know how to do the Ober test, and this will predispose the patient. Now, patella mobility should be assessed by doing the glide test. A force is applied in both medial and lateral directions, and translation is quantified based on patella quadrants, 15% of the width of the patella. So this is the glide test. So you have to compare the both knees. Many times it's only present on one side, or it can be bilateral. You have to test also see for the apprehension test, and you should know about the increased lateralization during terminal extension, which gives you a J sign. This indicates may indicate less of medial soft tissue checkerins. So you have to pay attention to this. You have to take the proper imaging, and you have to do measurements like the insole Salvati index, and you can do the Caton Deschamps index for measurement. This is the insult salvati. You measure the length of the patella and the length of the infrapatellar tendon, and it's 1.2. While Caton and Deschamps stress that we don't need to do this measurement. We do the measurement of the length of the articular surface of the patella divided from the tip of the articular surface distally to the proximal angle of the tibial plateau, and you do the measurements. And this is any value greater than 1.3 is pathologic. So you have to know these two measurements. And if things are normal, you have to do a tibial tuberosity osteotomy to correct the position. Some combine it with the Mackett procedure, where the displacement is anterior to decrease the pressure on the patella. This is for patella malalignment. But for trochlear malformation, it's a different approach. You have to know multiple things. You have to know about the crossing sign, what it stands for, what is the sulcus sign. You have to know about the supratrochlear bump or arch. All these are important. It's a supratrochlear spur, which is on there. This tells you that the patient has an abnormal trochlea and that tracking through the trochlea is not normal. And by taking a true lateral, you can see obtain the double contour sign, which is important to know in these cases. So de Jour made the classification of the various different types of congenital trochlea, and he divided them into 4 types. One is type A, in which you have the crossing sign, you have a sulcus sign, which is greater than 45 degrees. And in type 2, you have the spur, and you have a flat trochlear fossa, while type C, not only have a flat, you have a depression, and in type D, you have a cliff, or shown in this slide. You have to know the 4 types of trochleae in these patients. And this is the classification by de Jour. And CT and MRI help us a lot about this. Now, speaking about the repairing only the medial patellofemoral ligament with normal trochlea, then one should do proper measurements, of course, before doing it, making sure that the trochlear base is normal, yani that you have a good sulcus, you have a good tracking of the patella, but you have a soft tissue deficiency, and you want to do a medial patellofemoral ligament replacement. So you have to do, this is how we do the sulcus angle. This is the trochlear inclination angle. If there is a deficiency, it will be much less. And this is the lateral patella tilt angle of how we do it. We do it through both margins of the articular cartilage of the patella, and we draw a horizontal parallel to the posterior condyle. An angle greater than 20 degrees is pathologic and may indicate lateral retinacular tightness. So the distance between the tibial tuberosity and the trochlear groove, the TTG distance, this gives you the proper measurement of the different types of condyles, and it tells you about the what you call it, the trochlear fossa of how it is. You have to go through these measurements to know them. I put all these measurements for you to remember. So it's very important that you know it, but this will prolong the lecture so much, and we don't have time for it. If you see, these are the points we use for measurement of the axial view and the lateral view of a normal trochlear. You have to know where to put the measurements. You have to look at the patellar congruency between the articular surface and the trochlear. It is in good position. The crossing sign is shown over here between both condyles. There's a crossing sign, meaning that there's no trochlear. So you have to pay attention to this. So this is the trochlear bump. The trochlear bump is measured by drawing a line anterior to the bone, the femur, and a tangent parallel to that line on the bump, and you measure it. So if it's greater than 3 millimeters, this is pathologic. If it is less than 3 millimeters, it is not. This is the trochlear spur, and this is how different measurements are done. I want to show you. This is the trochlear depth of how we measure it. It's performed on a true lateral radiographic view, a tangent to the posterior femoral cortex, which is the red line, and the perpendicular line at the most proximal part of the posterior condyles, done to the red line. This is the most posterior part. And then, most proximal blue line, a yellow line is subtended 15 degrees from the perpendicular line, and this is now used to measure the trochlear depth. This is the amount of trochlear depth. You need to memorize these. You see, if I was asked these blindly, I would not know them, but you have to see them at your stage. You have to memorize them. Look at this, how we measure. This is done tangent to the posterior condyles, and then each, if you want to measure the height of each of the condyles, you draw a line directly to the most highest point, measure the differences. And then you have to know that the trochlear shift and the inclination of the patella. All these are important. So these are measurements to tell you about trochlear dysplasia. So don't forget, let me mention this. This is important. See, I have an overlap here. I'm suffering from it. The definition of a high-grade trochlear dysplasia is imprecise and has not been universally agreed upon. Both quantitative measurements and radiographic classifications are used. Many authors consider a high-grade trochlear dysplasia to be like a type B or D de jour trochlear dysplasia. Okay, so you have to keep this in mind. And what do we do? I want to show you what we do. But the results are not good. We found that. We've done quite a few cases at our institution. We haven't had, you see, tracking of the patella goes well, but this does not prevent degenerative arthritis. For some reason or another, these patients develop degenerative arthritis. What we do is we go through an approach, either medial or lateral, we remove. You have many reamers. We put our reamers in the center and we ream down. And we've got curved osteotomes. And we continue to remove it. We remove bone from here until it's really narrow. And on pressure, it breaks, but the cartilage remains intact. We have done a few of these cases, but I'll be very honest, the results have not been very good. At times you see that there is complete flatness. You can make an osteotomy and you can break it like this, like we did previously, and put bone graft to increase the trochlear shift. area so that the patella won't dislocate laterally. This is it. Let me show you. This is an osteotome. We pass it, we remove a wedge of bone over here, or we remove bone and create a wedge and put our bone graft. Then let me show you others. The goals of trocheoplasty: deepen the groove, correct the sulcus angle, eliminate of the prominence, position the new groove in a lateral position to decrease the TTTG distance and proximal realignment. You need to combine it with the soft tissue. There are many cases that we have done where we combined it with the repair of the medial patella femoral ligament. You have to realign the patella. If you have a lateral line tuberosity, you have to do a medialization of the tuberosity. If you have a patella alta, then you have to do distal implantation of the tuberosity together with slight medialization. If you have a lot of pressure, in the past we used to do a lot of a Mackett procedure where we increase the distance of the patella from the trochlea by putting a graft between the tuberosity that we have osteotomized and the tibia. So all these, look at this. This is what was done. You need the true lateral X-rays, CT scan, MRI scans. You should look for trochlear dysplasia, patella alta, medial patella tilt. I mentioned that you can elevate it, increase TTTG distance. And this is showing the spur. You see the spur, you draw a horizontal line over here and a tangent, and you measure the distance. Look at the crossing line sign. It tells you that there is a complete flattening of the sulcus, of the trochlea. This measures the spur line prominence. This measures the distance. This is the Deschamps, Caton Deschamps technique. And this should be 1.3, not more. This tells you about the complete loss of the trochlea. What we can do over here, we make an osteotome over here. We elevate this portion, we leave the cartilage intact, and we impact bone over here. This tells you about measurement of the TTTG measurements. Now, if you look over here, this is a procedure where this is what we have from the trochlea with the wedging. And you see over here what has been done. We have divided here. We removed bone. We created the wedge to deepen the sulcus. So there are many techniques. Goutelier technique is used. You have to look it up of how we remove this to do this. But I'll tell you, many of them on follow-up develop degenerative arthritis. So you have to know this is enough for trocheoplasty. Just you need to know that there are 4 types. You have to know that in type 1, you don't need to do much. You have to search for these types together with the soft tissue imbalancing, and you have to combine procedures to do them so as to overcome this imbalance. So this is what we do at our institution. Okay, you have a breaking the osteochondral flap, distal attachment of this flap, a too thin flap. We try to avoid it, decreasing it. These are problems. Let me warn you. This is the problem we have been faced with. If we remove too much bone underneath the cartilage, this would devascularize the zone where indirect nutrition comes to the cartilage. not through the synovial fluid, but through this. And we've had osteonecrosis, osteochondral necrosis. So you have to be careful on doing this. So there are many. One of the complications we get is stiffness. You need good amount of physiotherapy for these patients. We've had one case that went back to sports as was playing sports. The whole osteochondral evolves. So you have to be careful when to allow them to go to sports, not before complete union. You have to know, put them on a physiotherapy regime post-operative. Be very careful about this. Now, I'm coming to a section very quickly. I'm going to go through it because my time is nearly over. I would like to tell you what about the patellofemoral syndrome may result from extensive mechanical alignment with or without instability of the syndrome. And this could lead to instability and dislocation of the patella. I'm coming to patella tendinitis. Patella tendinitis is pain in the infrapatellar tendon, and usually they have inflammation of this area. You have to give them physiotherapy, you have to give them cold applications, anti-inflammatory drugs. In the past, I have operated on some of these patients, and I made a longitudinal incision through the patella, and I had a large amount of granulation tissue to remove. Then I resutured it. So you have to pay attention. It's an inflammation of the patella tendon, usually at its attachment to the inferior pole of the patella. Rupture of the patella tendon may occur with or without history of tendinopathy. The mechanism usually excessive jumping or bounding activity or high patellofemoral stress activity, less commonly from running. So you have to pay attention to this. And usually they present with pain in the infrapatellar region, and this is what brings them to you. And especially on flexion, they have this pain. So you have to pay attention to it. And I would say the differential diagnosis, no. Surgical treatment should be the last resort with unpredictable results. This is to the jumper's knee. Synovial plica, I'm sure everyone who does arthroscopy knows what a plica is. And the problem with plica is that it can be caught on the condyles. And there are some who say, well, why should we touch it? No, whenever you see a plica, slit it, cut it. And this will make motion very easier, and it will decrease popping sign while flexing or extending the knee. Remove the plica. You don't have to remove it completely, just slit it so that it will no longer be tight during flexion and extension. So enough for this. And I would like to mention Osgood-Schlatter's disease. We all know about it. Occurs in young individuals, usually towards adolescents. They play football. There's a lot of traction on the apophysis, leading to fragmentation. And they have a bump. Many of them come to you complaining of a bump in front of the leg, and they say it's ugly. Well, there's no treatment. I wouldn't advise any form of treatment to it. Then you have to know about ruptures of the quadriceps. They usually have tendon, you can have inflammation. We know that there are certain individuals who are predisposed to it. Chronic conditions like diabetes, like chronic renal disease, they can have ruptures of these tendons. And you have to examine the patient carefully, and you see that there would be a gap over here. due to, and the result is usually it's a forced flexion while the muscles are in the extended position. So keep this in mind. Of course, you have to suture these. Bursitis, there are many areas around the knee in which you have bursitis, inflammatory areas with bursa, which were meant to soften the range of motion. These can become inflamed and painful. So they can have pain in the pre-patella region, pain in the distal patella tendon region, which is due to the deep infrapatellar bursitis, pain in the proximal medial tibia, the pes and serenus bursitis, and pain over the medial joint line for tibial collateral ligament bursitis. And you examine them, you check this localized tenderness, and these you have to give them anti-inflammatories. If they don't improve, you can infiltrate around the area with cortisone, of course. This slide shows you the various types of bursitis. So acute pre-patellar bursitis, ice, compression, possible aspiration, padding, chronic pre-patellar bursitis, non-steroidal anti-inflammatory drugs, compression hamstring, ultrasound, possible aspiration, and corticosteroid injections, pes and serenus bursitis, likewise, plus corticosteroid injections, tibial collateral ligament bursitis, use injection both as diagnostic test and you have a deep infrapatellar bursitis, which is secondary to hamstring stretching, possible injection behind the patellar tendon. And this shows you the various types of bursitis. Neuromas do occur, especially if you're doing any procedure around the knee. You can cut the nerve, the saphenous nerve, and it will form a neuroma. And you have to do a Tinel's test on them, and they will suffer a lot from pain. You can have loose bodies, osteochondral fractures, which become complete. It's most common on the lateral surface of the medial condyle. We believe it's secondary to impingement of the eminence on this area. They can vary from a floating to a non-floating to a full covered area. We know that in children, the prognosis is better than in adults. Many times, if they're not healing, you can put bone pegs across the lesion. If it's pulled out, you can have to remove cartilage and bone from other areas, and you do a mosaic plasty. So this is as well. So let me tell you anything. Popliteal cyst. Well, you have to, when you get the popliteal or a Baker's cyst, you have to think of pathology within the knee joint. You have to look at pathology. It's due to fluid collecting in the knee and herniating to the outside. If you remove a Baker's cyst and there's pathology within the knee, then you'll see that it will recur after a short while. And this is quite common to occur in meniscus injuries. So, popliteal cyst, iliotibial band syndrome, thank God it's the final one. It is a rubbing of the iliotibial band on the lateral femoral condyle, and this gives you a clunk, and this could be very painful. It's secondary to tightness of the iliotibial band, and the way you can diagnose this is by doing an Ober test. The Ober test will tell you about the diagnosis, and this would be the result. In summary, multiple factors contribute to stability of the patellofemoral joint. Static restraints, dynamic restraints, osteochondral constraints, lower extremity alignment, patellofemoral disorders appear as pain or instability, identifying and treating the anatomical or functional deficits specific to the individual patient are crucial for directing non-surgical and surgical treatments. Surgery may be indicated in patients with recurrent instability after unsuccessful non-surgical treatment. The surgical procedure should be tailored to the specific dynamic and anatomic variations contributing to the patient's instability. Future directions in patellofemoral research include quantification and standardization of the measurements of contributing factors to determine the appropriate indications for surgical correction. So the take-home message, the clinician should differentiate between patellofemoral pain and instability based on the patient's history and physical examination. The etiology of patellar instability is multifactorial, and successful surgical management requires identifying and considering the contributing factors. The complications of patellofemoral instability surgery often can be avoided by using appropriate surgical techniques. Thank you. Thank you very much. I hope I did not bore you. شو يا جماعة؟
لا بالعكس بروف، مستمتعين اليوم، محاضرة ممتعة جدا جدا.
Was it clear? Was I clear? I tried my best. Look it, I'll
لا
tell you.
بارك الله
More
فيك.
clearing. يعني
محاضرة
كل شيء
ممتازة جدا.
طيب thank you very much. لهم للشباب كلهم مفروض يراجع، مفروض يقروا هني. نحن ما بنقدر نعطيهم كل شيء، هني بدهم يحفظوا، هني بدهم يقروا، نحن بنقرا لحتى نعطيهم،
تسلم
هني
بروف،
بدهم
تسلم
يقروا
بروف.
لحتى يخلوا عندهم. بقى مشان هيك اللي بنطلب منه إذا في الشباب رايحين على الفحص للأورال examination بمين الشهر بمصر، مفروض يعرفوا كل هول. لأن خليني أقول لكم أكثر الأوقات بنجيب cases عن الركبة، بنقول لهم examine them. We look at how the candidate, how well he examines the patient. And a good amount of our judgment to pass him or not is on how well he does the examination. Whether the hip, whether the knee, whether the ankle, whether the spine, whether the upper extremity, the elbow, the wrist. The wrist, we like to ask a lot of questions about it. The various examinations that one should know. The elbow, we likewise like to know a lot about pronation, supination, about the radial head, etc. إن شاء الله لوقت الجاي كونوا قدمتوا على الفحص ونجحتوا كلكم. تحبلكم أنا بدي أحكي مع الدكتور خالد، لأن الفحص بمصر بتكون ل 12 شهر، و12 شهر بيكون عندنا اللكشر الثاني يلي جاي من بعدها. بدي قلت له لدكتور خالد يا اما نعمل السبت قبل ما اروح او نعملها السبت من بعد ما ارجع، يعني من بعد 12 شهر. فبليز قولوا له اياها. قال لي دكتور خالد هو برات البلد، اذا بيقول لي اياها بكون ممنون. يلا باي باي.
اوكي دكتور.
Thanks.
شكرا جزيلا دكتور، شكرا جزيلا.
Thank you. خالد منه موجود.